Hello everyone, a very good afternoon to one and all. Today we will be discussing a topic. We will be going back to history, turning back the pages of history and understanding what is pain medicine, how it evolved, and a few concepts of pain medicine. So this is going to be the outline of my presentation for today. Introduction, history of pain medicine, a bit about physiology of nociception, that is about pain, understanding a few concepts about sensitization, followed by the conclusion. So let's have a look at pain medicine. So about pain, the oldest explanation of why pain was manifested in specific populations was rooted in religious beliefs. Majority of them believed that pain was a consequence of committing immoral acts or bad deeds. There was also a belief that suffering they endured was the individual's way for repent for these sins. To an extent, even in today's times, a lot of people think that you have to, whenever you get pain, you have to not treat the pain, but live with the pain, which is a totally wrong concept. Moving ahead. Let's have a look at a few theories of pain, of how pain evolved over the centuries across the globe. Initially, one of the first theory was something called as the intensity theory. There was a famous philosopher by name Plato, who was from Athens, and in his work Timaeus, he defined pain as not as a unique experience, but as an emotion that occurs when the stimulus is intense and lasting. So he was one of the first person who, synonymized pain to an important aspect of emotion. A lot of experiments were being conducted during the 19th century, and they provided important information regarding the threshold for tactile perception, the role of the dorsal horn neurons. Basically, this is all talking about the mechanisms of how pain is manifested and felt. Another theory was put forward in 1644 by the French philosopher René Descartes. It was called the Cartesian dualistic theory. It hypothesized that pain was a mutually exclusive phenomenon. So what he tried to describe is pain could be a result of physical injury or a psychological injury also. However, the two types of injuries did not influence each other, and at no point were they to combine and create a synergistic effect on pain, hence making pain an exclusive entity. He also included in his theory the idea that pain had a connection with the soul. He claimed that his research uncovered that the soul of pain was in the pineal gland, which is present in the brain, and consequently he designated the brain as the main moderator of pain. Now, what are the drawbacks of his theory? It failed to account for many factors that are known to contribute to pain today. It lacked explanation as to why no two chronic pain patients have the same experience with pain, even though they had the similar injuries. So this is a very important concept which you need to understand over here with regards to pain. For example, if you take two individuals and they have got the same amount of injury, but the reaction to pain is definitely not the same. So what is the reason for this particular difference is what this theory fails to explain. Now moving ahead to the specificity theory, this was presented by Charles Bell. It was similar to Descartes' dualistic approach to pain in the way that it delineated different types of different pathways. So, in addition to identifying specific pathways for the various pain inputs, Bell also postulated that brain was not the object, the main moderator, which Descartes believed it was, but instead a complex structure with various components. Moving ahead, Johannes Müller in the mid-1800s published in the Manual of Physiology that individual sensations were the result of specific energy experienced at certain receptors. Now, what are these receptors? Muller believed that there could be a number of receptors in the skin, and also this surplus of receptors accounted for the ability of an individual to discriminate different sensations. So basically, the receptors are there in our skin, which help us to identify with whenever our skin comes in contact with an object, be it hot or cold or painful. In 1894, Max Onfray made a critical addition to the specificity theory. His contribution was the discovery of 4 separate somatosensory modalities found throughout the body. So, what are these sensations? They are cold, heat, pain, and touch. So, these are the 4 main sensations in the body. This concept served to reiterate the presence of distinct pathways for different sensations. Coming to the drawbacks, it still fails to account for factors other than those of physical nature that result in sensation of pain. The theory also lacked an explanation for why sometimes pain persists long after healing of initial injury. Next, pattern theory, introduced in 1894 by Alfred Goldschneider, who was a German army physician who posited that certain patterns of nerve activation were produced by summation of sensory input from the skin in the dorsal horn. He found 3 kinds of sensitive areas in the skin: cold, warmth, and pressure, and was able to prove that each point reacted only to the specific stimulus. John Paul Nafe and Sinclair Wedall. Now, John Paul Nafe formalized this theory by expanding the concept that all sensation is the result of patterns, spatially and temporally, of nerve impulses rather than individual or specific receptors of pathways. Sinclair and Wedell expanded the pattern concept, emphasizing that all fiber endings, except those innervating the hair, are similar, and it's only the pattern that's important in sensory discrimination. Drawbacks, again, further research and discovery of unique receptors. This theory became inaccurate. Summation theory, put forward by Livingstone, Hardy, and H.G. Wolff, demonstrated importance of interactions between the various neurons, the receptors, the sympathetic nervous system, somatic nervous system in developing secondary hyperalgesia, etc., which became a forerunner in the later concept of central sensitization. So basically, what they noted that exacerbation of pain was present with repeated stimuli, which is nothing but hyperalgesia. Pressure sensation over time resulted in painful sensation, and pressure points responded differently to stimulation. Hence, the summation theory was proposed. Mr. Sherrington, described as the father of pain physiology, developed concepts of non-selective receptors and selective excitability. Let's come to one of the most important theories in pain. This is called the gate control theory, put forward by Ronald Melzack and Patrick D. Wall. So it's called the Melzack and Wall gate control theory. Introduced in 1965, this viewed pain through a mind-body perspective. They proposed that signals produced in the primary efferents from skin stimulation were transmitted to 3 regions within the spinal cord. That is the substantia gelatinosa, the dorsal column, and a group of cells they call transmission cells. They proposed the gate in the spinal cord is the substantia gelatinosa in the dorsal horn, which modulated the transmission of the pain. This mechanism was controlled by activity in the large and small fibers. The large fibers inhibit or close the gate, whereas the small fibers facilitate or open the gate. Activity from the descending fibers could also modulate this gate. So when a pain information reaches a certain threshold that exceeds the inhibition, it opens the gate and activates pathways that lead to experience of pain and its related behaviors. So it states that the larger diameter A beta fibers leads to inhibition of pain signals transmitted via smaller diameter A delta and C fibers. And the physiological gate is by the inhibitory interneuron. So here you are seeing, this is the pain signal, the A delta fibers on top, A beta fibers below. Okay. So whenever a pain is perceived, the pain signal, it is carried by both small nerve fibers and large nerve fibers. So what is happening over here? Mainly, if the pain is carried by the small nerve C fibers, the large A beta fiber, they have an influence over the projection neuron, the inhibitory neuron, and what they do is they cut off the transfer of the pain sensation from the small nerve fibers to the spinal cord or brain. The inhibitory neuron activated, blocking the projection neuron. So, what are the applications of the gate control theory? In TENS, which is transcutaneous electrical nerve stimulation, in spinal cord stimulation, and in peripheral nerve stimulation. Okay, so let's move ahead to the physiology of nociception. Now, nociception means the ability to perceive pain, ability to understand pain. So, nociception is carried forward by certain receptors, which are called nociceptors, and they present at free nerve endings of A beta, A delta, and the C fibers. So, these nociceptors or receptors can be activated by three types of stimuli. They are thermal, temperature, mechanical, stretch or strain, and chemical, which is pH change. Coming to the neural processing, this is nothing but sequence of events which are involved in neural processing of noxious stimuli, which leads to pain perception. What do these include? Four processes: transduction, transmission, perception, modulation. So here you are seeing what these are. So transduction is conversion of the painful stimulus by the nociceptors into electrical signal or action potential. Here transduction is happening. You can see injury is there. And then the painful stimuli converted to electrical energy. This process is called transduction. Transmission. Here the action potential generated at the nociceptor is propagated along axon of primary afferent neuron. Here you can see the transmission. So there are different fibers that carry pain. A delta and C fibers. A delta are the fast fibers. C fibers are the slow fibers. A delta carry rapid and sharp pain, well localized. C fibers carry slow, diffuse, and dull aching pain. Then coming to perception, the cortex, somatosensory cortex, is associated with sensory and discriminative aspects of nociception, while the deeper structures are associated with the affective component of pain. So here you can see the perception. Here we have, what are the structures carrying out perception? Sensory cortex, limbic nuclei, thalamus, reticular formation. Coming to modulation, it's a process which acts to reduce the pain. Now, remember, modulation is one of the most important processes or activities for reduction of pain. A lot of the painkillers, what we use in today's times, especially the co-analgesics, they follow this approach, this mechanism of modulation. So if you see over here, this is nothing but the modulation. Again, you can see the modulation over here descending in pathway, which has one of the most important, and this is the body's strongest pain controlling mechanism. Let's move ahead. In modulation, we have the endogenous pain modulation system, wherein endogenous opioids like endorphins, enkephalins, and dynorphins act on the opioid receptors and help in pain relief. We have segmental inhibition. Local inhibition in the dorsal horn is mediated by release of inhibitory neurotransmitters like GABA and glycine. And lastly, the gate control theory of pain, which we already saw. Descending inhibitory pathway, the periaqueductal gray matter and rostral ventromedial medulla in the midbrain send descending fibers which project into the dorsal horn of the same set of tissue damage. So what is activated by? Serotonin and norepinephrine. If you remember, most of your co-analgesics are serotonin and norepinephrine reuptake inhibitors. So they send inhibitory signal and reduce the pain signal. Now, what do you mean by nociception and pain? What is the main difference? So nociception is nothing but it's a neural process of encoding and processing noxious stimuli, right? Whereas pain is a more complex phenomenon which cannot be reduced to only activity in the sensory pathways. Pain arising from activation of nociceptors is called nociceptive pain. Okay. And nociceptive pain can be classified depending on which tissue is there, like skin, which is superficial somatic, deep somatic, ligaments, tendons, bones, and visceral, which is the internal organs. Let's have a brief look at the autonomic nervous system. We all know it has two main divisions, sympathetic and parasympathetic. They are functionally and anatomically distinct. So sympathetic outflow is thoracolumbar, T1 to L2. Parasympathetic is craniosacral, right? Exits through cranial nerve 3rd, 7th, 9th, 10th, and S2 to S3 sacral nerves. So this is the sympathetic nervous system and the parasympathetic nervous system. And here you're seeing the various actions as well. For example, if sympathetic dilates the pupil, parasympathetic is going to constrict the pupil. Okay, so there is certain mechanism called somatosympathetic coupling. This is all important, especially for neuropathic pain conditions. Now, this is a certain crosstalk which occurs at two places. One is at three sites. One is the DRG, dorsal root ganglion. Other is any injury, peripheral nerve or neurolysis, and sympathetic efferent fibers. Now, why I'm talking about all this is because this is an important mechanism for neuropathic pain conditions, especially CRPS. So, what you need to understand over here is sympathetic nervous system. The sympathetic efferent fibers, they release catecholamines, which instead of acting on sympathetic receptors, stimulate the nociceptors, which normally are stimulated by mechanical, chemical, and thermal stimuli. These nociceptors generate action potential, which are carried by somatic nerves. So there is a mixing which is happening, and this is why it is the mechanism for examples like CRPS. So let's have a look at sympathetic blockade and its significance in pain management. Sympathetic blockade results in interruption of transmission by both efferent and efferent fibers. It does not result in sensory and motor loss as seen in somatic blockade. So now, for example, anyone coming with CRPS of upper, now CRPS is complex regional pain syndrome, especially of upper and lower limbs. If they come, then stellate ganglion or T2, T3 can be tried for upper limb. Lumbar sympathetic is tried for lower limbs. Now, for abdominal cancers, okay, for stomach cancer, pancreatic cancer, etc., splenic plexus, celiac plexus block give the desired pain relief. For cancers affecting the pelvic region, cancers of uterus, urinary bladder, etc., the superior hypogastric plexus block is going to help. Okay, let's have a look at the phenomenon, the mechanism of something called as sensitization. Now, what is sensitization? It is nothing but defined as increased responsiveness of nociceptive neurons to the normal input and or recruitment of a response to normally subthreshold inputs. It's a key feature of neuropathic pain. Two types of sensitization are there, peripheral and central. So peripheral occurs due to changes in the peripheral nervous system, right? Now, what are the factors which play an important role? Upregulation of active nociceptors, sensitization of primary efferent terminals, ectopic discharges, and phenotypic switching. And somatic sympathetic coupling. Coming to central sensitization, it's sensitization as a result of changes in the central nervous system. It's called central sensitization. So, what are the factors that play an important role? Central reorganization, disinhibition, ectopic discharges, wind-up phenomena, and activation of WTR neurons. So, what you need to understand over here is what are the various, Now, why all this is important for you is to understand. I'm not going into the molecular level of sensitization because first we need to understand this concept of sensitization, why it is very important. If you remember in the beginning of the discussion, I was talking about how two patients having the same amount of injury, but they will not feel the same amount of pain. One may have less pain, whereas other may have more pain. Now, the explanation of this is nothing but the phenomenon of sensitization. So, in sensitized, whenever sensitization is more in an individual, what are its effects? See here, effect of sensitization are it increases the intensity, area, and duration of pain. Okay, it decreases the tolerability of pain. It results in development of psychological problems, and pain becomes unresponsible to the conventional analgesics. So what you need to understand is if an individual is sensitized, then you have to understand over here is the patient, that person's pain area duration is more compared to another person. The ability to tolerate pain is also lesser, and there is development of psychological problems as well. Remember in the beginning, in one of the theories where pain was described as an emotional experience. Yes, pain and emotion go hand in hand. There is definitely a psychological component to the pain. People who are in, anxious, depressed, more in depression, they feel more pain compared to other individuals. And the last point becomes very important over here. Pain becomes unresponsive to conventional analgesics. That is, the patients are taking painkillers, but still the pain is not responding. The pain relief is not happening for them. All of this is due to the phenomenon of sensitization. Another very common example of sensitization is fibromyalgia. Right, with this, my take-home message for today's talk is a good knowledge in pain physiology and its mechanism is of paramount importance for any pain physician, because you have to understand what the patient is going through. For that, you need to understand what mechanisms are happening, because whenever a patient comes to you in the pain management clinic, especially the neuropathic pain conditions like fibromyalgia, CRPS, etc., many of the time there is no external injury as such, but internally the patient is in a lot of pain, which you need to understand and treat. Sensitization is a key feature, as I had put in the previous slide, of neuropathic pain. Understanding these concepts helps to develop effective treatments to alleviate most of the pain syndromes. These are my references. Thank you very much for your patient hearing.